Let's move on to the winner of oral presentation in the track of systematic review and meta-analysis entitled A Network Meta-analysis Comparing the Impact of Fecal Microbiota Transplantation, Medicines, and Supplements on Low-Density Lipoprotein Cholesterol, presented by Oranut Chatsirisakul from Faculty of Medicine, Chulalongkorn University.
Hello everyone, my name is Oranut Chatsirisakul from Chulalongkorn University. Cardiovascular disease, stroke, and other vascular-related diseases are the leading cause of death globally, and high LDL cholesterol is a major risk factor. While statins are the most commonly used treatment, they often cause side effects, and newer therapies like PCSK9 inhibitors and ezetimibe are costly and not widely used. Emerging treatments like fecal microbiota transplantations and probiotics have shown promise in reducing LDL cholesterol, but their comparative effectiveness to traditional medications remain unclear. My research conducts a network meta-analysis of randomized control trials using Bayesian's approach to compare statins, PCSK9 inhibitors, ezetimibe, FMT, probiotics, and radiatrides in terms of LDL cholesterol reductions. The result could provide crucial insights into more effective and accessible cholesterol management options. Hello everyone, my name is Oranut Chatsirisakul and I'm a fourth-year medical student from Chulalongkorn University. Today I will present my research titled A Network Meta-Analysis Comparing the Impact of Fecal Microbiota Transplantations, Medicines, and Supplements on Low-Density Lipoprotein Cholesterol. Cardiovascular disease is the leading cause of death worldwide, and high LDL cholesterol is one of the biggest contributors. Not only cardiovascular disease, high LDL can cause strokes and peripheral arterial disease as well. The most common treatment for high LDL is statins, but they often cause side effects that many patients cannot tolerate. So we invented other drugs like PCSK9 inhibitors, but they are very expensive, and for ezetimibe, it's coming with less efficacy than it's on its own. And recently, a growing area of research is looking at the gut microbiome and probiotics effects on LDL levels. Fecal microbiota transplantation, or FMT, is a procedure where healthy bacteria from a donor stool are transferred into a patient's gut. Normally, it has more efficacy than probiotics. However, it's still unclear whether FMT and probiotics could be a better option than traditional drugs. There's also radiatrides, a supplement that works quite similarly to statins, but its safety and effectiveness are still debated. To sum the problems up, current treatments for high LDL cholesterol have significant drawbacks. FMT and probiotics efficacy is still questions. These intervention effectiveness on LDL hasn't been directly compared. So this research aimed to rank the efficacy of these treatments and see if FMT and probiotics could be a viable option for managing high LDL in the future. The main objective of this research is to compare FMT, medicines, and supplements on their ability to lower LDL cholesterol. And let's move on to the methods part. We follow PRISMA for network meta-analysis in our research. First, we search through PubMed, Scopus, and Central using relevant search strategy as shown here on the screen. After screening the paper using confidence, we ended up with 28 studies for data extractions and grade approach as shown in the PRISMA flowchart here. And for our inclusion criteria, where RCT does compare statins, PCSK9 inhibitors, ezetimibe, FMT, probiotics, or radiatrides with a control group. Study were excluded if the full paper was not in English, combined interventions, or patient got other comorbidities apart from dyslipidemia. For the analysis, we use mean differences calculated in Review Manager 5.4, and we also use Meta Insight software. And here's the results part. Here's the data extractions for table contains 28 studies. And here's the Bayesian network map. We included 9 interventions from 28 studies involving a total of 5,394 patients. The size of the nodes indicates how many studies examine a particular treatment. And the thickness of the ages show how many studies compare to treatment directly. The number on the lines indicate a number of trials conducted for each specific comparisons. And here's the forest plot. Overview of the forest plot showed that FMT is the only intervention that did not show significant results on reducing LDL-C. Heterogeneity was moderate to high in the data, as shown here on the screen. And here is the Bayesian relative effect. The forest plot of the Bayesian random effects model found that ezetimibe, radiate-rise, FMT, and probiotics did not show statistically significant results in terms of relative effectiveness. This suggests that these treatments have less clear outcome compared to other interventions. And here's the Bayesian sugar ranking. Sugar stands for surface under the cumulative ranking curve. Let's take a look at a radial sugar first. The metric ranks treatment based on their effectiveness with higher sugar values indicating better performance. The size of the nodes correspond to the number of the participants, while the thickness of the line reflects the number of trials conducted for each treatment. And here's a litmus rankogram show how each treatment performs relative to the others. Treatment with higher sugar values are positioned toward the top left, indicating better performance in lowering LDL-C. Overall, the ranks show that rosuvastatin is the best, followed by PCSK9 inhibitors, atorvastatin, simvastatin, radiate-rise probiotic, FMT, and ezetimibe, as shown on the screen. And we also did a great approach considering within study bias, reporting bias, indirectness, imprecisions, heterogeneity, and incoherence using the node splitting method. While there was moderate to high quality evidence for some treatment comparisons, others were downgraded due to concerns about imprecision about broad confidence intervals or small sample size, high heterogeneity, or lack of the direct evidence. And now let's move on to the discussion part. Overall, our results align with prior studies on statins, PCSK9 inhibitors, and RYR. Rosuvastatin showed the greatest reductions in LDL-C. Simvastatin was more effective than radiate-rise, which had less impact on LDL-C due to variability in the potency of its active ingredients, monocolin K, as stated in the previous published research. Both FMT and probiotics were more effective than ezetimibe at lowering LDL-C, supporting probiotics as a promising supplement for cholesterol management. FMT, which altered the gut microbiome, showed potential, but its clinical role is still emerging, and the limited number of the study may explain the less conclusive results in my study. And for the conclusion, statin and PCSK9 inhibitor drugs show better options than others. However, our findings on FMT and probiotics highlight an emerging area of research that could change how we manage LDL-C in the futures on our patients. The strength of our study is that we included a wide range of interventions and found that FMT and probiotics outperform ezetimibe, adding new insights into microbiome-based treatment for cholesterol. And the limitations, most studies focus on short-term effects and there was variation in study design, sample size, and also the quality. For further studies, should consider for long-term effects and doses, focus on patients with other comorbidity or other disease, and explore probiotics or FMT combined with other treatment for enhanced efficacy. And that's all. Thank you for your attention.
Surely this presentation inspired us all. Do you have any comments or any questions?
Thank you so much for your presentation. Why you select for the statin, why you select only simvastatin, atorvastatin, and rosuvastatin?
Well, because when I'm searching using the search strategy, at first, I saw only these three as the most popular use in the dyslipidemia and the publications used for dyslipidemia in RCTs. So I included them into our study. Yes.
And for your the search term, why you, I saw that you did not add the term PCSK9 or acetamide in your searching.
Oh, well, actually, I added it, but maybe on the slides, I didn't show much because, we have limited space. And actually, when I'm doing the search strategy, I doing a lot, for probiotics, I adding more just probiotics word for sure. Other bacteria names, I also added. Yeah, but I'm just cannot show because the limited space, sorry.
And your population are only the primary prevention, or you include both primary and secondary prevention for the cardiovascular disease?
I included only people with dyslipidemia, only with no other comorbidities. Yes.
Okay, thank you.
So did you searching for the lifestyle modifications as the one of the treatment to decrease the LDL level?
I have also searched about lifestyle modification as well, but others have done this kind of research on the lifestyle modification comparing with other drugs already. So I see the space for the probiotics and FMT, which is a new method for the lowering LDL-C because it's have less efficacy. No, it's kind of less side effects than statins because statin maybe can disturb the gut microbiome and cause dysbiosis and other side effects like hyperglycemia come from statin as well. So that's why I choose probiotic and FMT in my research. Thank you.
You can argue that you have to compare with the placebo also. So I think the lifestyle modification is one of the standards management in this disease. So the placebo group, that means receive nothing. That means they might receive only lifestyle modification. Yeah.
Thank you.
Thank you.
From your study, could you give more suggestion for the clinical improvement to treat the patient with dyslipidemia?
More for further studies.
Just like from your result, could you give the hints or the information that we might improve or is we should do for this topic?
I think not only for the main drug, we also use statins as a normal in like almost all the hospital. But for my idea, as from the data I got, I think from statins, it can cause dysbiosis, which is the disturbance of the gut microbiome in our body. So maybe we can include probiotics in our patients, like we tell them to eat statins, but also give a probiotics into them as well. So they will be kind of have a good gut microbiome while the statin is working at the effective drugs to lower the LDLs. For FMT, I think it still need more further studies on them because like other ethics, like we use the healthy bacteria from the donor stool, and there's kind of like conflict, like they did the diseases like the blood donation. So I think more studies should be focused on these FMT and the probiotics we can use in the guideline and others in the hospital to treat patients with more efficacy.
Any more questions? Thank you so much.
And the question is, how does your research contribute to solving real-world challenges, and what potential impact could it have on society or public health in the future?
My research directly addresses the global health challenge for cardiovascular disease, stroke, and also other vascular-related disease, which remain the leading cause of death worldwide. A major contributor is high LDL cholesterol, and while main drugs used are effective, they often come with side effects or are very expensive, limiting access for many populations. My research investigates alternative approaches, specifically fecal microbiota transplantations, probiotics, and red yeast rice that could offer a viable, lower-cost option to manage LDL cholesterol, particularly in resource-limiting setting. In my research, it showed new insight on microbiome-based approaches that FMT and probiotics outperform ezetimibe, which is the traditional drug. So if FMT and probiotics prove to be effective options in public health, they could offer a significant breakthrough in providing not only cheaper, but also safer treatment options for a population who cannot access expensive or high-risk medication. This could have a profound impact on reducing health disparities, especially in low and middle-income countries where healthcare infrastructure is limited. Moreover, this study laid the groundwork for more personalized treatment, moving beyond a one-size-fits-all approach based on individual needs and microbiome compositions. By providing evidence for the efficacy of alternative interventions, my research could influence global healthcare policies, encouraging greater integrations of these options into clinical practice and expanding access to care. Ultimately, our study discovered that FMT and probiotics outperform ezetimibe, add new insights into microbiome-based intervention, which help to reduce the burden of many diseases worldwide. It could improve health outcomes, particularly in all populations, and contribute to a more equitable healthcare system globally. Thank you.